Okay. Thank you for joining the Michigan Center for Rural Health Infectious Disease Echo. If you could, well, let me introduce myself. My name is Renee Calkins, and I have the privilege of moderating today's session. Today's topic is evaluating patients with COVID long haulers. Just some housekeeping. For a more collegiate environment, we will use first names only. Please be conscious of confidential and protected health information. Please keep your microphone on mute until you're ready to speak. Before you speak, please say your name so we know who is speaking. The presentation will be available following it with the email and your CME credits in a follow-up email after this session. The value of ECHO is in the case studies, so definitely please volunteer cases. And I would like to ask everyone to rename your ECHO screen names to show your first and last names. You can right click on your circle and it should say rename. At the end of the session, if you could just type in the chat box about something you learned from the day and you can take back to your practice. And are there last questions before we begin? All right, well, with that, I would like to introduce Peter, and thank you for being here, Peter.
No problem.
We'll be on long COVID syndrome. Thank you so much.
Yeah, so today's talk, this is a difficult talk because there's not a lot really understood about this condition. We know it exists, and the CDC is defined it and given some certain parameters about it, and there's been even funding by the NIH to try to better do more studies on this condition, because just to give you some basic parameters about this condition, long COVID syndrome, between 10 and 20% of COVID survivors develop this syndrome, and that's one study. There's several other studies that say the incidence may even be higher, and anywhere from 7.5 to 23 million people have this condition, and about over a million individuals have been out of work regarding this as a result. And it has actually been defined now by the CDC and the NIH, et cetera, as a disability. But it's very difficult to prove it because the bad news is we don't have a defined test that I can order to say, yes, you have long COVID syndrome, or no, you don't have it. And it's mostly a condition where you have to look at a bunch of different factors, which we're going to discuss today. We do know that it tends to have individuals with certain risk factors, individuals that are older, individuals that have severe COVID to begin with, women tend to be at higher risk, although we've seen it in asymptomatic individuals and younger. So, you know, this is kind of a condition that's all over the map as far as what we've found with it. And again, it's something that, let's go, next slide, please. Good. So this condition, as you can see here, this is describing the entire COVID infection. And so you can see back in phase 1, early stage, people get infected, they get the virus in their bloodstream, they get symptoms, they test positive on serology, and many of them resolve at this point. They don't go any further, but then there's some that go into the next stage, which is the pulmonary stage, where now they get the virus into their lungs, and the virus then causes lung problems with pneumonia, and it can be very serious, or it can be mild or serious. And if it becomes more serious, then they have to be admitted to the hospital, and many of them end up on a ventilator. And then you have this cytokine storm, which occurs where the body reacts to the virus. And this is what is felt to cause the severe COVID condition, where the cytokine storm goes just crazy. All this inflammation occurs, so you get heart problems, kidney problems, lung problems, and it can be a very, very ongoing thing. Fortunately, a lot of individuals, most individuals, recover from it, but then we have this final phase where you see the little gentleman sitting there, and this is the post-COVID syndrome. And this is, it's been defined as long COVID, post-COVID, little definitions, but they found that there's 4 factors that tend to be involved in causing this syndrome. Individuals that have a lot of virus in their bloodstream or a high viral load during these different phases tend to be at a higher risk. Individuals that have type 2 diabetes for some reason have a higher risk. There seems to be a correlation with another virus, the Epstein-Barr virus, which some of you may or may not know. It's the one that causes mono, but it was also the virus that was linked to the chronic fatigue syndrome, which we saw years ago. And it's been called different names, but that was one name that kind of stood with it. And it tends to be this COVID virus, long COVID syndrome tends to be linked with people that have Epstein-Barr virus. And many of us have it. We've been exposed to it. It goes into a latent phase and nobody gets bothered by it, but this may have an impact on long COVID syndrome. And then individuals that have autoantibodies, and that's why women tend to have a higher risk, because they tend to have more risk factors for autoantibody related diseases like lupus especially. And so this is where, you know, these are different factors that might interact with forming a high-risk individual that may be at risk for post-COVID syndrome. It's a very expensive disease. It's felt to cost individuals at least $9,000 per year per person as far as the cost of taking care of somebody, and that's just average. And it's felt that there's about $149 billion in medical expenses, as well as $362 billion in lost expenses related to this post-COVID syndrome. So this is kind of the syndrome. It can occur after severe COVID infection. It can occur after mild. There's even cases reported with asymptomatic COVID syndrome. So next slide, please. So what are symptoms that people get that sometimes define the entity of post-COVID syndrome or long COVID syndrome? And this is something that, again, is defined as somebody that's had acute COVID infection, they resolve the acute infection, and then they may either persist with symptoms or the symptoms go away, but then they recur and they persist for beyond 1 month and sometimes beyond 3 months and even 6 months. So it's one of those conditions that usually the symptoms go away, but then you start getting symptoms back again and they persist or worsen after different periods of time. But these are some of the symptoms that they report. Severe fatigue is one of the commonest symptoms, where people just can't get over the tiredness, the fatigue, and it can interfere with normal function. It can interfere with their daily activities. It can interfere with work. Headaches that persist or that are ongoing. A lot of times chest pain, where the pain can be, mild or severe, and where this might be related to a myocarditis or it might be related to some lung injury as well. And then having just major aches and pains or numbness, tingling of the feet or hands can be an avenue of this. People that have lost their sense of smell and taste, this may persist and can be ongoing as well. Related to lungs, the cough might be persistent or ongoing and might result in also shortness of breath, palpitations, and then some GI issues like gastrointestinal, nausea, vomiting, diarrhea, abdominal pain, and then just this cognitive abnormality where patients get forgetful, brain fog, so to speak, and then they can get some neuropsychiatric problems where it can involve anxiety, depression, post-traumatic stress disorder. And so these are different conditions that can occur with the post-COVID syndrome. There's a lot of them. They're not really specific, but the ones that tend to be defined in most studies are the dyspnea, the shortness of breath, the chest pain, rapid heartbeat or that, brain fog, and the fatigue. The fatigue tends to be the most common symptom at about anywhere from 20 to 72%. But then some of the, like I mentioned earlier, the respiratory symptoms, the shortness of breath can be up to 40%. The exercise intolerance, where somebody used to be running marathons every month and now they can't even walk from one side of the house to the other, may occur up to anywhere from 10 to 40%. And this might be related to lungs, to heart. different things like that, or they get this rapid tachycardia, spontaneous, where all of a sudden their heart just goes like 150 beats a minute and then slows down. Then it goes off again with minimal exertion, which results in sometimes postural hypotension, where they try to get up from a lying position and they basically almost pass out because of this parasympathetic, sympathetic, autonomic dysfunction. So these are the real conditions that really, are current in post-COVID syndrome. Now, next slide, please. Where we're concerned, though, we're concerned in general, we're concerned about the symptoms I just mentioned, but where we have to be very careful as healthcare providers is that these are areas where we have to be very careful and rule out, because these may require specialty care. So these serious complications may be less common, but they still may occur with many of the symptoms I just talked to you about. So individuals that have, for instance, severe chest pain or shortness of breath, or exhibiting signs of heart failure, need to have a workup, because one of the complications of COVID is myocarditis, and pericarditis can occur. So these have to be ruled in or out, and they have to be done because, it's not just a generalized complication of COVID, but it's more specific. The other condition is respiratory. So individuals that have had prior history of pneumonia or severe respiratory symptoms may persist with that, with shortness of breath, dyspnea, cough, that may continue to go on and may lead to more complications. And when you do lung function studies, they're abnormal, their CAT scan shows scarring. And this is an individual that needs to go to a specialty clinic. Individuals that have neurologic, like I said before, not only the ones that have loss of sense of taste and smell may be predisposed to more complicated neurologic problems, because that's the olfactory bulbs that lead up into the brain, and they may have problems with brain fog, encephalitis, sleep disturbances, all kind of complications that may enter into psychological problems of depression, anxiety. And a lot of us like to just refer to the post-COVID syndrome as a psych disorder. It's not a psych disorder. There can be a lot of other objective abnormalities with it, and psychiatric can be just one of them, but it can be very, very serious. And so my real point of this slide is to make you aware that these are conditions that, with the primary care, with the healthcare providers, you might want to get specialty consults to try to rule, try to work these up there, because like I said, these conditions in post-COVID can lead to rather serious consequences, and not just something with fatigue, etc. Next slide. And, the prevalence of long COVID, this is just an estimation, obviously, and you can see the different colors in the map here. And if we look specifically at Michigan, anywhere from greater than 500 to 1 million cases have been reported in Michigan. So again, this is something that's an estimate or guesstimate based on individuals coming into clinics and then being reported. And you can see the map on the left-hand or the right-hand side, where you see the incidence of COVID increasing. The COVID surviving cases obviously is a good factor, that people are living with it and, and recovering from it. But the long COVID syndrome also is increasing as well. And I know there was a recent report by Dr. Fauci just recently, where he said this is a condition that we may not be really concentrating on, because of the fact that we're getting less deaths, we're getting less hospitalizations and things, but this long COVID syndrome persists and is increasing, and really may take a real major hit on the economy and on the long-term quality of life of people that have been exposed to COVID. And this is where you may ask yourself, well, isn't it better just to get natural infection rather than try to get vaccines to prevent you from getting COVID? And really, when you get natural infection, no matter what degree, asymptomatic, mildly symptomatic, or severely symptomatic, you are at risk for the long COVID syndrome. And this is something that in patients that have been vaccinated, and I'll get into that, I may be getting ahead of myself, but people that have been vaccinated, there may be an actual lessening of the condition of post-COVID syndrome in people that have been vaccinated. Not that they can't get it, but it might not be as severe as what the results are. Next slide. This is very difficult because what are the causes of long COVID? How do we define it? What are the different things that occur as a result of it? And so there's a lot of money going into this. We don't quite understand it, but these are some of the potential concepts of what's happening here. First of all, there's individuals that get, persistent inflammation and immune dysregulation. So meaning that the body is supposed to react normally to an infection with immunological, stimulation, getting rid of the pathogen, and then the immune system quiets down and life is good. Whereas this condition, some people have a dysregulated immune system where it doesn't know how to stop. It just keeps throwing out inflammatory proteins, which cause damage to the body. Even when the infection is over with, everybody knows the post-COVID or the cytokine storm is mainly an inflammatory reaction. It's not related to the virus directly. It's an indirect result of the virus causing this inflammation that goes out of control. And what happens is people get on the ventilator. This post-COVID syndrome may be a situation where the same condition occurs, not at the high level of cytokine storm, but at a lower level where you have constant immune, stimulation going on. And then what this can result in is sometimes autoimmunity, where it's a dysregulated immune response that results in the body reacting to its own self. And that's what occurs in systemic lupus and rheumatoid arthritis. Well, this may result as a result of a viral infection where the body can't recognize its normal body, and it can cause inflammation of the muscle, of the brain, of the heart, and all these symptoms of shortness of breath, dyspnea, mental fog, muscle aches and pains are a result of this condition. And then having, virus that's still in reservoirs. So we don't know this either. Are there viruses that are hiding in different parts of the body that are continuing to cause the body to cause immune stimulation in this dysregulated immune system? And that's another potential theory that's going on. And then causing damage to the blood vessel cells, so the endothelial cells, so people are at higher risk for, cardiovascular disease, thrombosis, blood clots. We've heard all about that with COVID and with post-COVID syndrome, and just with various cardiovascular complications. And then finally, directly invading the nervous system. And is it more than just, anxiety and depression from having, from being sick? Is it something where it directly affects the brain cells themselves and causes depression, anxiety, brain fog, forgetfulness? So it's a very serious, long, extensive condition here that we don't understand the principles of. So we can't really diagnose it because we don't know what's causing it directly, and we can't treat it directly because we still don't know the pathogenesis. It's not like HIV, where we've defined what the virus is doing, how it's doing it. We know how to measure the virus, and we know how to treat it. This is a virus we know, but we don't know too much about all the long-term complications. Next slide. So risk factors for long COVID, what are the risk factors? And we've talked a lot about the risk factors. This is where, people, we've kind of identified, women as being at a higher risk because they have a propensity to autoimmune disorders and dysregulated immune system. We've talked about older age individuals, but then younger people can also get it. Even young children can get this post-COVID syndrome. So, it's not really regulated necessarily by age, although older people tend to get it more severely and things like that. And then obviously having a severe bout of COVID with a high viral load might influence the body's ability to react to it, and then the virus going into reservoirs. This is where vaccines may be definitely an advantage, because a vaccine, you've heard, people still can get COVID despite being vaccinated, but they don't get it as severely. So the viral loads aren't as high. So the reservoirs aren't there. So the body doesn't react to it as severely. And so this may prevent us from getting long COVID syndrome by being vaccinated appropriately and things like that. And then pre-existing conditions. We've already talked about type 2 diabetes being a problem, and individuals that have a predisposed autoimmune disorder. These are all conditions where these are individuals who may be at higher risk. And next slide, please. And so looking specifically at some of the symptoms. And again, this is what I'm trying to do for you today. I'm trying to educate you when you see patients come into your office and they have symptoms like this and they've had a history of COVID and they're still coming in and they're saying, Doc, I just can't get back on my feet. Well, COVID was 3 months ago, but I'm still tired. I can't walk. I can't do my running anymore. I can't even think clearly anymore. These might be all signs of post-COVID syndrome, of the long COVID syndrome. And you can see here, the different, conditions that occur and the percentages of them occurring based on, the different color codes. And you can see here that, individuals with acute COVID, that's in the blue line, they tend to have a lot of these symptoms early on. And then as you go, the green is the lighter green is 5 months after the acute COVID. The yellow is 9 months after the acute COVID. And then the dark green is 12 months after the acute COVID. And so basically what you want to see here is you can see that different symptoms may persist longer, like for instance, fatigue, dyspnea, poor concentration, trouble finding words, insomnia. You can see those green lines, those dark green lines, which is 12 months later, are still persisting. And so those are some of the symptoms that tend to persist with patients with long COVID. Next slide. But look at this. This might be a little bit complicated to try to understand, but long COVID can occur after a breakthrough infection, meaning that you've, like Paxlovid, for instance, or whatever, controls the initial, but then you get another infection afterwards. But they're lower in vaccinated versus unvaccinated individuals, at least in several studies, tend to show that they're not as severe. And by getting the appropriate vaccines, like if one just gets one vaccine where they're supposed to get, obviously the primary vaccines are 2, and then getting your appropriate boosters after that, if you miss some of those, it may be eliminating some of your benefits from protecting you from this long COVID syndrome. But there's been evidence, and there's some good evidence, that by vaccinating yourself appropriately for post-COVID, or for COVID rather, that you will protect yourself against the severity of this long COVID syndrome. You may still get some symptoms, but they may go away, they may be lessened, et cetera. So this is another plea to make sure that individuals are vaccinated appropriately. And this is where a big problem is now, with the new bivalent vaccine. It's incredible how many people have not gotten it yet, and how it's really, you should really educate patients not only in protecting against the against the acute complications of COVID, but the vaccine may be protecting you against this long COVID syndrome. Next slide. And so symptom frequency in vaccinated versus unvaccinated. So again, looking at the colors, the blue is basically uninfected individuals. And so you can see there, it's kind of a control, fatigue. Obviously there's, people that have different symptoms that are uninfected just based on other factors that cause fatigue, headache, lingering. So that's the blue. The gray is vaccinated with 2 doses. The yellow is vaccinated with 1 dose, and the green is an unvaccinated individual. So look at the high levels all along, from fatigue to headache to limb weakness, muscle, etc., with the green and the yellow. So the green is unvaccinated, the 1 is vaccinated, and this is primary vaccinations, 1 dose. So they just got 1 dose, but they didn't get the 2nd dose a month later. And then compare that with the gray, which is somebody that's been vaccinated at least with 2 doses of vaccine. And you'll see that the gray bars are definitely much lower in all the different areas there: shortness of breath, persistent cough, etc., when you compare it with the only 1 vaccinated versus unvaccinated, meaning that definitely vaccinations tend to seem to really reduce the frequency of complications with long COVID and symptomatology. Next slide. So now getting a little bit more specifically into evaluating and caring for patients with post-COVID. And before I go into that, any questions? All right, next slide. So I'm going to give you a little bit of a background. Next slide. And so the post-COVID condition is kind of, or long COVID. I'm going to use these terms interchangeably: post-COVID, long COVID. And it's an umbrella type term. And you can see here that it mainly talks about both physical and mental health consequences in patients that have basically presented 4 or more weeks after SARS-CoV infection. So you're seeing a patient in follow-up, they've had COVID a month ago, 2 months ago, and they're complaining of complaints, physical, mental, or both. This might indicate more of a patient that might be presenting with the post-COVID syndrome. And so these are individuals that could have had initially severe symptoms, they could have had mild, or they could have even been asymptomatic, and now all of a sudden, they went in and got tested because they were exposed, and they found out they're positive with no symptoms. And then a month after their serology, was positive, and they went into isolation, et cetera, et cetera. A month later, now all of a sudden they're starting with symptoms. They're having headaches, unexplainable headaches, fatigue, tiredness, out of the blue. And you're thinking, what is this from? Well, it may be related to long COVID syndrome. Next slide. So they're heterogeneous. They're not just a simple, everybody has the same symptoms and they're all basically the same. There can be different types of presentation. So a person could have acute COVID and then recovered from it as far as his serology goes. He became PCR positive, now his PCR there, but his symptoms are still there. He's still having the headache. He's still tired. So he's never really, the symptoms never really left. They just persisted. Or he got asymptomatic COVID, and now a month later, he's got all these symptoms, headache, fatigue, tiredness, like I just mentioned earlier. Or there's an evolution where patients had initially the real serious problems, and then as they went on in their, incubation, not incubation period, their time, in isolation, and now they're starting, their fevers are gone, their shortness of breath is better, things are better, but then the symptoms, come back again, or they get worse. So they kind of get better, and then they might disappear, and then a month later they come back again. And we don't know why. Is there different pathophysiological processes going on? Are there other factors? Patients obviously have other illnesses that they could have that could contribute to some of these symptoms as well. And then, like I said, other viruses can do the same thing. And the Epstein-Barr is the big one. And I already told you, one of the areas of individuals that are higher risk for the long COVID syndrome are ones that have pre-existing Epstein-Barr infection as well. So could this post-COVID syndrome, could this inflammation reactivate another virus that is sitting in your body that's kind of latent and make it more active as well, like Epstein-Barr or another herpes virus? So these are some of the conditions, but it's a very difficult condition to understand. Next slide. And it affects millions of individuals. I already gave you the stats behind that. The literature will give you different numbers here and there, but I'm going by basically, more, like the CDC and the NIH, where they do these big study groups and studies. And I'm going mainly by their statistics rather than an isolated group here, an isolated group there. I can tell you that there's COVID clinics being established all over the country. In Michigan itself, I know the University of Michigan had a COVID clinic early on, post-COVID clinic rather. Beaumont Hospital had one, and I think there's probably some other areas in the state that have them as well. And for the primary care providers out there, it's not that every patient that has a symptom or something that you've evaluated and think it's post-COVID necessarily has to go to these. I mean, if you feel uncomfortable or if there's complications that you feel are there, then maybe send them to one. But definitely if they have evidence of one of these organ dysfunctions like cardiac, like we talked about, cardiac, neurologic, respiratory, et cetera, then they definitely should be going to one of these clinics for more extensive evaluation, because many of these clinics are multifaceted. They have neurologists, they have psychiatrists, they have cardiologists, they have pulmonary, and they form a multi-specialty clinic dealing with post-COVID syndrome to try to evaluate them in a much more detailed manner. But this condition can affect children, it can affect adolescents, And it's challenging because trying to look at all the different groups that could be at higher risk. Next slide. And so these are associated with a spectrum. I keep bringing this up over and over again, that could involve both social, psychological, as well as physical consequences. It's not just a simple one symptom disease or one area. It's a conglomerate of a bunch of different areas where people can have depression and anxiety. And it shouldn't be just dismissed as being, well, you're just recovering from a viral infection, so you're depressed and anxious. It could be part of this post-COVID syndrome, which is a underlying physiological problem. It's not just a mental disorder. I mean, mental disorders are physiologic too, but it's not just something you can dismiss easily, but it can be a real serious problem, and it can involve multiple areas that are both physical as well as psychological. Next slide. So what are general considerations? Next slide. Well, when you're seeing a patient, you want to really listen to them, listen to their complaints, spend a little time, validate the experiences, and try to identify different types of health goals here, because again, the primary care providers, the healthcare providers are the main structure where they're going to be seeing the majority of these long COVID syndrome patients. And again, these are the ones, you're going to be the ones to manage them, to try to define what's going on, to try to dismiss some other condition that might be, hiding, that might cause symptoms like for instance, chest pain. Obviously, you might be thinking, well, it might just be related to well, you want to rule out a heart attack or something like that, something really serious as well. So remember that as well. And then again, consider referral to a multidisciplinary post-COVID center if you feel this patient is more complicated than just having symptoms, fatigue and different things. But if their dyspnea is really severe, if they've got really severe chest pain, that you're worried about a myocarditis, if they've got, significant encephalitis where they not only have brain fog, but they're really encephalitic with forgetfulness, and they need to go to a specialized center for that. And again, the way you diagnose many of these is based on excluding other conditions, but based on their history and their physical exam. But you got to remember that we don't have a specific test or anything that we can define this condition with. So, be careful of not doing excessive testing if it's not necessary at this particular time. And again, usually you're more conservative, or the recommendation is be more conservative, define them, not isolate, define them, talk to them, try to find out different ways of controlling it, especially during the first month to 3 months. And many times, a lot of these symptoms will subside and they'll get better, and patients will learn to accommodate themselves with it. So, you don't have to go on a diagnostic explosion and order every test in the book initially. But if symptoms persist or they worsen, and especially if they go beyond the 3 months, now you have to really start working them up more or sending them to a post-COVID center to see if something more can be done. Next slide. So what is the suggested workup? Next slide. So these are, again, the reported symptoms. Again, it's a huge list here. I mean, I can't, I'm sorry about it, but this is the list that's mainly seen. You can see fatigue tends to be the most common symptom. Dyspnea tends to be right there with it, with cough usually, malaise. Those tend to be very common symptoms. And then the cognitive disorders with the brain fog. And that tends to be one that tends to be there where cognitively they're not quite, they can't remember things. They can't function at work. And this leads to a lot of disability, just the fact of that alone. And then many times with that comes depression and anxiety, which is part of the psychological aspects of it as well. And then, the cough, the chest pain, we've talked a lot about these early on, but these are the symptoms you have to talk about and get into more detail to see if they're related to the COVID syndrome or something else. And, again, it's very important for many of these things to be monitored very closely. Next slide, please. This is where, again, I'm going to emphasize the fact that this is clinically where you want to, not just dismiss something and say, well, you're tired, so just try to do some physical therapy or try to, do this, that, and the other. But this is where you don't want to just dismiss it, but you want to rule out something more serious. And so again, I'm going to stress the fact, if it's a chest pain or an arrhythmia that you find, or they have a post-postural orthostatic syndrome, you want to rule out an organic problem, maybe a myocarditis or a cardiac failure from the myocarditis or an autonomic dysfunction. And the same thing goes with the other conditions listed there. If you have somebody that's got the shortness of breath, the dyspnea, and you're hearing abnormal lung sounds, doing a more extensive workup, maybe with PFTs, pulmonary function studies, CT scans, might be a helpful thing. And then looking at just basic labs. And if you notice the renal function is bad, then this could be a function of the of the COVID syndrome with the inflammation of the kidney, where there's people that have developed acute renal failure that then develop into chronic renal failure. And it might exacerbate somebody that's already got a kidney disorder, like from a type 2 diabetic. They might already have pre-existing renal that the COVID syndrome really exacerbated and worsened. And then obviously other conditions, rheumatologic, with the severe pain, myalgias, arthralgias, worsening diabetes, hypothyroidism, and on and on. So you can see the list there. But again, this is a slide that I think is important to concentrate on when you're evaluating long COVID or post-COVID syndrome, to make sure we're not dealing with these more severe problems where they may, again, need a more extensive evaluation in the specialty clinic. Next slide. So besides doing an extensive history, you have to do a very thorough physical. And part of that physical is going to relate to different signs of, looking for the, signs specific to COVID. If they have weakness and they have, signs of fatigue, tachycardia, you might want to do different testing to make sure they don't have, an orthostatic postural hypotension, or they have some other condition that might be related to, COVID involving the heart or the autonomic system, et cetera. So again, doing an extensive physical exam, looking for any other abnormalities is very important in working up a patient with post-COVID syndrome. Because remember, it can be a non-specific autoimmune dysregulation where you get a lot of these symptoms, but nothing real specific, or it could be directed toward a specific organ system like the heart or the autonomic system or the lungs or the kidney. And you want to be able to differentiate that because the one may require more intensive care. Next slide. And at this time, no laboratory test can definitely distinguish post-COVID condition from other etiologies. And so a positive viral test is not required to establish the diagnosis of post-COVID conditions. I mean, a history of having COVID before and documented, but they don't have to have an active positive virus at the present time. And again, lab testing guided by clinical findings. If you find somebody that's got, abnormalities, where you're worried about they have, tachycardia or skipped heartbeats or something, you're going to want to do an EKG, or if they're short of breath, maybe an echo of the heart, or, more intensive patterns based on what you're finding on your physical exam. But again, remember that during the first 4 to 12 weeks, you're going to want to, evaluate them and observe them a little, see if they can recover a little bit, and kind of recover from it. And so a basic lab panel, CBC, CMP might be appropriate, but not going into more extensive labs, at least at that present time. If they persist or worsen, especially if they go beyond 12 weeks, then you want to look at it more. And somebody asked a question about these symptoms seem almost very similar to fibromyalgia, and you are absolutely correct. Remember, the Epstein-Barr virus had been defined years ago as causing fibromyalgia, chronic fatigue syndrome. I forget the newest name for it, chronic myalgic encephalomyelitis, where this Epstein-Barr is a persistent virus as well. And people that have Epstein-Barr and get COVID may have a worsening or more propensity toward the post-COVID syndrome. So this fibromyalgia definitely could be a syndrome of post-COVID or long COVID syndrome. Next slide. And so looking at the test, and you see they're divided up into, tests that, basic diagnostic tests, to consider if the patients had symptoms for 4 weeks or beyond, up to 12 weeks. I mean, you might want to, get some blood, get blood counts, get a, check the liver, check the thyroid if they're tired, fatigue. When you start getting into inflammatory markers, be careful. It's a quagmire, because people can have inflammation from a number of things. So when you do a C-reactive protein or a sed rate or a ferritin, these are all, indicative of inflammation. But you got to be careful because we don't have a definition yet of what constitutes long COVID or what to do when we have an elevated CRP or sed rate. I mean, what do you give them an anti-inflammatory? Do you give steroids? What do? You don't know. So, be careful with these. I mean, if you want to, I think some of these COVID clinics are doing studies now, evaluating people with different symptoms and then trying to see if there's different things like that to define. And so that's where, inflammatory markers, but, evaluating thyroid and things, because patients can become hypothyroid from COVID or from other causes, and they can have fatigue, tiredness, et cetera, et cetera. So you want to do this as well. Once they go beyond 12 weeks, then you want to really go into more detail and see if they have an autoimmune condition like rheumatoid arthritis, lupus, or even a non-specific autoimmune condition from COVID itself. And so you get into that, or you do the coagulation things, because if they have endotheliitis, which could cause heart problems, could cause, ischemia of the heart, it could cause increased risk for clotting, minor clots or major clots, then you do more specific D-dimers, fibrinogen, or if you're worried about a myocarditis, troponin. These are different tests where now you've got to get more specific and more detailed, especially if symptoms persist or worsen. And somebody asked a question about a COVID nodule in the lung. Not that I know is a specific, like a nodule that's in the lung that could be defined. COVID in the lungs will present with a lot of interstitial lung disease and maybe some minor, small, ground glass appearance, things like that, but not a specific entity. But yeah, people with post-COVID syndrome, they can do that as well. And, a good comment just came through the chat box. Could it stimulate an autoimmune process? Absolutely, because as we know, COVID can cause a dysregulated immune system, and that can stimulate an autoimmune phenomenon. So, again, people can all of a sudden develop this severe, inflammation of the joints and the muscles and other conditions, and have positive autoantibody testing, and it can be because the COVID somehow stimulated a propensity for that to happen or caused it in and of itself. So very good questions. And again, trying to just give you a little bit of direction as far as where to go. So yeah, the first 4 weeks to 12 weeks, you can do a routine CBC, CMP, thyroid studies, et cetera. But then if things persist or get worse, then you can either start on your own and do the testing or send them to a clinic and let somebody else do that in well. And another question just came through on severe joint pain. And absolutely, severe joint pain could be a propensity to post-COVID syndrome. And, another autoimmune phenomenon or something that could be definitely there. And so would require further workup and that, especially if it's a diffuse joint, not just like a knee or an elbow, but all the joints are tending to be in it. And if you see characteristic changes like edema, redness, things like that, that automatically starts getting into the category of an autoimmune phenomenon. Next slide. And so the other thing you want to do is do testing to monitor the status. Are they getting worse? Are they getting better? Or are they in the same function? So these are different selected assessment tools, looking at, and I'm not familiar with many of these different tests. I do know some of the neurologic Montreal cognitive assessment, mini mental status tests, but these are tests you can get a baseline on somebody. If they have cognitive changes, do a baseline mini mental status or a Montreal cognitive, do a base, and then see them back again in a month. And if they're still complaining of it or worsening, do another one and get some more objective findings to their subjective complaints. And again, the same thing can be said about functional, respiratory, psychiatric, et cetera. They all have different testing that can be done to give you a baseline assessment of somebody that may be presenting with a psychological problem or a respiratory problem. You can get a baseline evaluation and then do another test, a month later, 2 months later, or whatever, and see if they're progressively getting worse or better or about the same. I mean, these can include, baseline blood gases or just oxygenation or, lung function studies or things like that. Next slide. And then exercise testing, patients that complain of fatigue and exercise intolerance. The same thing, you get baseline, you do the different tests that are listed here, the different 2-minute step test or the 6-minute walk, something to get a baseline objective finding and then repeat it again in a month or 2 months to see if it's progressively getting worse or better or about the same. So these are just different tests that you could do to assess that. Next slide. And then what about some of the more fancy tests, the imaging tests? Everybody wants to get into the fanciest tests right up front. We'll be very, very, very careful of that because sometimes, if you have somebody that's complaining of shortness of breath, but their oxygenation is good and no physical findings in that, running right away to a CT scan or a pulmonary angiogram. I mean, you got to be careful about doing some of these more high-level testing without more objective findings that you're finding on your physical exam and things like that. So it's not that you shouldn't do them. It's the appropriate time to do them, or maybe you want to refer them again to a special center and then have them approach these different tests. Because like I said, these patients are at risk for serious problems. They can get progression of their lung disease. They can get microangiopathic disease of their endothelial, where they get micro clots in their lungs, where an angiogram might be appropriate, or God only knows with the brain, encephalitis, microvascular disease in the brain. They could get brain clots up there as well, leading to cognitive changes and other things like that. So these might merit consultation with specialists. Next slide. All right, the toughest area, management. How do you take care of these patients? Next slide. Well, this is where you have to define what you're dealing with and then develop some kind of a plan as far as rehabilitation. If they're severely fatigued, if they have exercise intolerance and things, trying to get them into a program where they can work on these different processes. And then, doing different management techniques for their dyspnea and things like that, working with them on some type of a recovery program, some type of a rehabilitation program. And again, primary care providers, really are at the baseline of this because they can provide a holistic support of the patient throughout their illness, not just concentrating on the lung or the liver or the spleen or whatever. They're dealing with the entire patient, the psychological aspects, the mental aspects, the physical aspects, all the aspects. And so they don't pick patients apart into pieces. They treat the whole patient. And so you guys are really right at the forefront for doing most of the care of many of the long-term COVID patients. Next slide. And again, some groups may require special consideration. Where we're trying to define long COVID syndrome, and where Dr. Fauci brought this up in several other articles, a lot of the risk groups are the racial ethnic minority populations. Many times they're the ones that don't go in for care right away. And so they get the serious bouts of COVID. They don't get treated quickly. They don't get the vaccinations that they should. And then when they get the long COVID syndrome, they don't even go into care to get evaluated for them. So many of them are ones that are not being treated because they're not getting into the healthcare system. So these ones have to be monitored very closely because they can develop severe long-term COVID syndrome. And patients with disabilities obviously have a similar problem. In patients that are homeless or in correctional facilities, these are all individuals that would be at a high risk for developing severe COVID syndrome or prolonged COVID syndrome that's never been diagnosed, treated, evaluated, anything. And so they all require specialized care, and not to forget them, but to include them in doing evaluations and substance abuse disorders, rural clinics. So many of you in rural areas, which, we're talking to right now, that have these patients that are substance abusers, that are homeless, that are that. These are individuals that really, really do require evaluation and care, because many times the condition can get out of control in these individuals. So these are ones that I think require special considerations. Next slide. So clinical and public health recommendations. Next slide. So documented of the post-COVID condition is critical for accurate public health surveillance. And, you know, there's a coding guide for this. There's a code listed there by the World Health Organization. It's not currently available in the United States and is under review, and they have different ICD-10 committees and things like that. But again, it's a condition that's trying to be defined as a special entity that needs to be defined as an entity and evaluated through that entity. And, you know, trying to get more and more data is only as good as what data is sent to the different areas there. So a lot of these, you know, COVID clinics are obviously working with bigger institutions, trying to get as much data together, trying to get studies together, trying to get more research. And that's the way we're going to define what this entity finally is, through this kind of coordinated effort. Next slide. And then they should, you know, obviously people with the post-COVID condition should follow CDC's prevention measures, and they should definitely be considered and continued on their vaccinations. Right now, I didn't get into this. I have a whole talk on this as well, on variants. And, you know, right now we're looking at the winter season, and we're not looking so much at different Greek letter variants, meaning beyond Omicron, but we're looking at subtype variants with the Omicron. We're looking at the, you know, A1.1 or not B1.1 or B.7, or there's all these subvariants. And what's worrisome about them is this Omicron, you know, variant itself is able to mutate in and of itself and change different structures on its, you know, spike protein, where it's more immunoevasive. It may not respond as well to some of the monoclonal antibodies like Evusheld, or the other one that's out there that's being used in patients that have, you know, acute COVID. So we're really kind of, you know, not chasing our tail, but we have to be very cognizant of the fact that there's a lot of new strains, and it's really significant that we try to get on top of that and make sure that our vaccinations are maintained, and that we're up to date on those, that we get the flu vaccine, because we don't want the flu to exacerbate somebody that's already got COVID to make the long-term COVID even worse. I mean, that could be a synergistic environment as well. So we have to make sure right now, getting ready for the winter season, that people are vaccinated appropriately, both for COVID as well as for the flu, and make sure everybody's in that particular category. Next slide. And let's see here. And then, preventative practices, trying to make sure that patients get the proper nutrition, physical activity, sleep, stress management. This is where the primary care, again, really does do the service for the patient, rather than just isolating a patient and just treating their lung or their heart. But this is the primary care, the healthcare providers like yourselves that deal with everything, you know, making sure that they're getting proper nutrition and all this other stuff. And then preventative health screenings, vaccinations, and et cetera. Next slide. And then finally, more research. I already kind of alluded to this. It's a prolonged illness. We don't have the idea. We don't have the pathophysiology behind it. We need more research. We need more data on the long-term effects of COVID. We need to understand better what these symptoms are, why they recur, you know, what the full effect is on patients, what the likelihood of recovery is. We don't have the answers to a lot of these questions, but these are questions that are going to have to be answered, you know, and this is only through more and more studies. Final slide. And this was just a slide I just put up here for. I can't comment on any of these, but these are some of the investigational agents that are being looked at for long-term COVID. Some of them involved, you know, like the CCR5 antagonist. That one I'm familiar with, in the fact that with HIV, that's how we block the virus from getting into cells. So maybe an antagonist that prevents a receptor from being infected by and the CCR5 is a chemokine receptor that can activate the lymphocyte and cause more immune activation and more cytokines to be produced. And so by blocking those, could it block some of the effects that the COVID has on causing autoimmunity or inflammation? And, and different anti-inflammatory products. Interferon beta is a innate immune product that helps to get our first line of defenses effective against viruses. And so maybe some of those reservoirs where COVID is, maybe some of these different, interferons might benefit from clearing these receptor reservoirs out. And then available drugs that are out there right now, you can see the list there. I've seen reports on a lot of different drugs being used and looked at, and everything's up in the air right now. I just think that, you just need to do practical baseline care of these patients and, make sure that they're in proper, that you've worked them up properly, ruled out other conditions, and that if they are more and then baseline monitor them and making sure they're not progressing. And if they're progressing, especially beyond 3 months, then maybe referring them to a big critical care center for more, not critical center, but a more comprehensive care center for more evaluation. So I'm out of time right now. I hope this was educational for you. It was a tough talk to do for me because I have more questions than answers, and I wish I had better answers for you. I hope, though, that this gave you at least a baseline, and it's nice to see so many individuals involved in this talk today. If you want to further, if you want any further topics related to COVID, I'd be more than glad to get that for you, because I want to have you guys, happy with what's being taught to you. So I can talk about variants at one point. I can talk about, care of a COVID patient with some of the oral therapies we have, whatever you want. If you want to strictly limit ourselves to COVID for a while, I'll be glad to do that. So just let me know. And again, thanks again.
Thanks, Peter. And if you have any questions, go ahead and unmute yourself. We can stay on for, I don't know, a minute or two.
Yeah, any questions or anything? I guess, Renee, you can look at the chat or look at any questions they might have to see if there's anything that I can answer for them or give you the answers and you can get back with them, whatever would be good. But yeah, it's really great to see such a participation here with so many people interested, over 30, and so that's why I want to keep this going. I want to keep the interest here. So give me ideas about what you want me to present in the future, because I'm just doing things that I think are good, but you may want something specific. So majority wins. So if there's a majority that want to hear more, let me know.
There was just a couple of when they registered questions like,
yeah, sure, give them to me.
How to help them get back to their best, the best ways to support or educate patients on their rehab.
Yeah, I think that's a great question. And I think, that gets back to, evaluating them, especially, giving them encouragement too. If they're just a month post-COVID and they're right now worried that they're not going to get better and this and that, try to, obviously do an evaluation, rule out anything that might be serious. But if it's just related to the post-viral syndrome or post-COVID, then just giving them little advice on, maybe doing, walking or exercise, nutrition, those kind of things to try to get them back on the road, so to speak. And you might want to do some baseline testing just to see how they were at that 1 month visit, and then see them back again in another month or two, and then reevaluate, see how they're feeling at that time. Do your baseline again, repeat it to see if it's the same or better. And if it looks like the same or better, give patients encouragement that, because a lot of them will recover. It's not like everybody that gets COVID is going to get long COVID and going to progress to end-stage disease, the majority, but you got to just rule out other things and then rule out anything serious related to COVID, and then just give them the proper rehab and the proper encouragement and make sure they're eating properly and they're not, abusing themselves. Make sure their prevention is up to date on the vaccines. I can't stress that enough, especially for the winter. You got to really make sure they're vaccinated properly. Other questions, Renee?
One was how other common geriatric medication can exacerbate symptoms.
How, what now?
Other common geriatric medications may exacerbate symptoms, memory medications
Oh,
or psychotropic
oh,
medications.
I'm not sure what, but yeah, if they're taking different psychiatric medications because they have an underlying depression or they have an underlying anxiety or whatever. Yeah, sometimes, this long-term COVID might exacerbate one of those conditions. You have to reevaluate them because, if their depression all of a sudden gets really worse or their anxiety gets really high level. And, some of them get the post-traumatic stress disorder, PTSD, if they've had severe COVID. And sometimes just plain insomnia because they can't sleep, they're sleep deprived, can exacerbate an underlying psychiatric condition. So you have to reevaluate these people. You can't just leave them on the same medicine, like they're stable on the medicine they're on for their post-COVID, for their psychiatric problem or whatever. And now all of a sudden they're getting worse after COVID. It might be related to the post. So they might have to be changed, their meds have to be changed, or they have to be given higher levels, things like that. But they just have to be changed. They have to be evaluated in that way.
Thank you. One of our comments said they have a client doing hyperbaric therapy. Is this something that may be helpful?
That's a great question. Hyperbaric therapy. I've heard all these good things about hyperbaric oxygen and helping mental function improve and helping a lot of sorts. That's a whole new area. That would be something that would be very interesting if somebody, kind of looked at that in more detail and say patients that are presenting with, with any symptom, with shortness of breath or definitely with cognitive changes by increasing oxygenation, would that improve function and would that reduce inflammation? I have no idea. That's a very, very, very good comment, but that would be something you might consider. I mean, that, as long as it's not doing any harm to anybody, I mean, the benefits might definitely be there. I mean, you look at it physiologically and there's a lot of benefits, especially with some of the symptoms patients with post-COVID exhibit, a lot of the neurologic symptoms or even cardiac, might definitely be something.
And then it seems our hospital practitioners do not acknowledge COVID as a cause for many of these conditions. Any suggestion on overcoming this?
Yeah, I mean, it's just more and more education. You have to be up to date on everything you're dealing with. You can't just sit in a little vacuum or a little closet and expect things to be the same tomorrow as they were today. And COVID changes so much, I can't keep up on it. I mean, just preparing for this lecture here, the slides I had, some of them I really have to, I mean, it changes by the hour and things I thought were right yesterday are wrong today. And so everybody has to just continue to be educated on it and don't assume that it's just a condition that just causes a viral infection, goes away. There is a condition, this long-term COVID is a problem. We just haven't defined the pathophysiology behind it. So I just would just plead with all practitioners, hospitalists or private practice or wherever they're at to just stay educated on it. And that's why we're trying to do programs and do as much education as we can to update everybody. It's not like we know everything, but we try to bring them up to par so that they're at least up to date on the most current areas there. So that's the only advice I can give. And you can lead the person to water, but you can't make them drink it. So you just try to do your best.
It looks like we had 2 more from the online registrations if we have a minute.
Yep, as long as you want.
Where is it? How would this affect advanced directives with as long as COVID?
Advanced directives. Does that mean like hospice or something like that? Or I'm not sure how to answer that question. I mean, the long-term COVID, we don't know the underlying pathophysiology, so we don't know the true effects of it long-term. So could it really cause a long-term, really debilitated problem? It potentially could. That's why, they're, trying to define disability with COVID is tough because, the disability services all want, some objective evidence that this person really needs to be labeled as disabled. And we don't have a lot of that ability with post-COVID. We don't have a test or anything other than indirectly, like showing that they have severe lung function or they have inflammation of the heart or something. So those are the only ways we can, define somebody as disabled or, that kind of situation. But yeah, we don't know the end stage of COVID and who is going to progress to more serious problems, who's going to remain stable, or who's going to get better. That would be a real good thing to do. It's almost like what we were doing with the chronic fatigue syndrome. And we haven't, like that's still out there. It hasn't disappeared, and the Epstein-Barr virus, but it's just something that we haven't really done as much research on. It seems like the COVID virus tends to be doing more inflammation and stuff like that, where it's causing more acute problems that we're dealing with that lead to chronic. I'm sorry to the person who asked that question if I didn't answer it, but that's the best I can do.
And then the last one I see here was the best initial best oral antibiotics for symptoms of pneumonia in a COVID positive patient.
Oh boy, that's a good question too. I mean, because there's so many causes of pneumonia, outpatient pneumonia. I mean, they can be atypical, like mycoplasma or chlamydia pneumoniae, or even Legionella in some of the more seriously compromised patients, or they could be bacterial, like pneumococcus is number one cause, or if they're a smoker, Haemophilus influenza. I mean, the only thing I can say there is define what you're dealing with. Don't just treat, treat from the hip, so to speak, where you're just starting to put somebody on one antibiotic and another one just because they have a persistent cough or something. Make sure you define that that's what it is. If it is an infection, try to be as specific as you can, and try to, then you could treat it appropriately. As far as a specific, one antibiotic could treat everything. I mean, you just can't define that. My training has always been be specific and don't treat too broad spectrum, because every time you treat with an antibiotic, you got to remember you change the normal microbiome of your GI tract that can influence a lot of other complications. And I didn't get into that, but just real quickly, they feel that there might be something with the microbiome of your GI tract that might influence long-term COVID too, because remember, the GI organisms in your GI tract influence a lot of your body's function, as far as how you, how you live and how you, cancer prevention and different types of, like C. diff is a good example. What happens when you use too many antibiotics? So you want to be very careful. And if they have an infection, treat it, obviously, but be narrow spectrum. Don't use a quinolone if the organism is sensitive to amoxicillin. That's probably my best way of telling you that. Don't use a broad spectrum if you can do it with a narrow spectrum. And vaccinate people. Make sure they're vaccinated for pneumococcus, and make sure they're, they don't get those bad pneumonias.
Thank you. And if there's any questions from the audience, go ahead and unmute yourself.
I'm just really impressed with the amount of people that are still on right now. And I just want to emphasize the fact, with this kind of a showing, let us know, let Renee know what you want me to talk about in the future, and I will present something more specific or get more, because I want to have a good audience like this. This shows a lot of interest, and I'm willing to talk about anything you want. So give her suggestions, or if you want me to do some cases, I can come up with some cases too. We can go over as well. So let me know.
Yeah, please email me if you have any suggestions. We can definitely work.
Yeah, work with it, because there's all kind of different topics out there. I can only do infectious disease stuff, but there's still plenty of those we can do. So let me know, let Renee know. So, because I really want to, give the audience what they want. I think this is very, very good.
All right. Thank you very much, everyone, for attending. Exactly. For staying over with us. We really appreciate it. Please email us, renee.calkins@affiliate.msu.edu if you have topics or cases you would like to hear.
Yeah, and if you want to go over more post-COVID syndrome, you have more questions, you want to have a question answer period, just let Renee know. Let her know, and then we'll deal with it.
Perfect. All right. And I will give you guys a follow-up email with the recording, the presentation slides, as well as the information to get your CME credits. So again, thank you, Peter, for being here, and thank
Yep.
you for attending, everyone. Have a great afternoon.
Bye-bye.